know.
Sorry.
No problem. So, Raj, you're up. I should call you Rajesh, but I understand only your mother does
Yeah,
that.
please. So I want to thank the Academy and Dr. Anderson. I'm going to, in the interest of time, kind of shorten the talk and just go through it quickly. If obviously we can answer questions at the end, and I'm certainly available at the end. So when I got asked to do this talk, we thought about what we would show from Cigna, and we thought we would talk a little bit about our embedded care coordinator's journey. And the idea was to kind of show you how we started, how we amplified and scaled our programs, and then what we're doing to go forward in the 2015 era. So the PR material is on that slide. Cigna has a number of collaborative care programs. Basically, this is what we called our alternative payment models before APM became a word or a phrase. Within our collaborative care models, we have what's called our collaborative accountable care, which is essentially an ACO. As you can see at Cigna, we like the letter C very much in all our programs. So the idea of our CAC programs is to deliver the triple aim of improving quality, affordability, and patient experience. The CAC works to engage patients and primary care providers, and at the center of the CAC is our embedded care coordinators, or ECC. An ECC is typically a nurse who is hired by the CAC or ACO and works with Cigna to provide patient-centered care, personal care, and coordinated care. And we do this and we make it successful by Cigna providing the information, sharing actionable information, if you will, the clinical integration part of coordinating the care, and then a very large physician incentive to financially drive that care. I'm going to skip this patient story. Jeremy did a great job this morning. So what I thought I would take you through is the learning curve, which was our learning opportunity from 2008 to 2011, how we grew and amplified it from 2012 to 2014, and where we are now in 2015 as trying to do some focused integration for our high-risk, high-cost patients. So the learning curve, when we started, we actually started with 8 CACs with embedded care coordinators. The learning curve was very steep. When we started, the physician groups and the nurses really didn't know a lot about care coordination. We actually had to send a clinical manager out, fly out there, meet with them once a month or every other week. We developed a predictive modeling tool, which is one of our proprietary tools, but it was very crude to begin with, and we were basically using our gaps in care to help identify high risks. We spent a lot of time educating what a care plan was. We initially sent out reports quarterly because of technology limitations. And then we learned that the nurses really didn't know a lot about telephonic management, telephonic coaching. So we had to develop all these skills in the early years. When we decided that we needed to amplify this, and currently we're at about 140 CACs across the nation, we couldn't do it one-on-one. We developed a resource guide, which is in its 7th iteration over 3 years to keep continuing to get better. We did a virtual training, which we still do twice a month. They call in and we do a virtual training for our embedded care coordinators. We figured out that the CACs were much better at teaching each other than we were, so we developed learning collaboratives. Initially they were face-to-face, now they're virtual. The way to get invited was to do a poster, and I'll show you a poster here in a second. We assigned a dedicated Cigna case manager to the ECC, and I'll show you the importance of that in a little bit. We improved our predictive modeling, developed disease triggers, hospitalizations, EDs, gaps in care. We developed a web-based portal to integrate daily census reports, and we now start pushing out our claims data monthly. We made a much closer alignment to pharmacy and behavioral health. And then from our very successful CACs, we developed a rapid design and innovation targeting the high-risk patients. So this is one of the posters. This is just a demo to show you from our Cigna Medical Group, which is one of our CACs. Basically, they couldn't get to their gaps in care and mammography, so they outsourced it to their radiology department, which was kind of interesting. And their radiology department made a humongous improvement in their mammography rate over time. Some of the more sophisticated CACs have actually developed their own high-risk identification within our profiles that we send them. Some of them recognize the need for social workers. They've hired their own social workers and added social workers to this. And the very successful CACs now have assistants for their ECCs, recognizing that their embedded care coordinators need to work on very high-risk people, and those middle-risk people where there's still a lot of gain to be obtained can go down to their assistants or their medical assistants. So they've gotten very innovative as they've done this. What are the lessons we've learned? Well, we learned the usual lessons. You know, you need to see a patient within 30 days of hospitalization. High-risk patients need to see 3 PCP, have 3 or 4 visits a year with their PCP. If they're seeing specialists, they need to see them at least twice a year. This is all published information. This is some of the unique things that the successful CACs are doing is they've developed a template or a checklist with their embedded care coordinator and their PCPs. They go through the checklist monthly or weekly, depending on where they feel the patient is. Our embedded care coordinators, successful ones, talk to our Cigna case managers on a weekly basis telephonically, and the really successful ones actually talk to them on a daily basis. And then going back to the EMR, we found that linked EMR systems were successful. Our IPA CACs, which don't have a linked EMR, are not very successful. It goes to the heart of interoperability, which is really something we need to work on here. And all this proved to reduce admission and improved care management for the patients. So how are we doing? Well, 74% of our CACs with 2+ years have shown success, both in cost and quality. It takes about a couple of years to get to the learning curve. You have to be relatively patient with them and work with them. 91% have reduced costs, 78% have improved quality. We've shown our client employers a 2-to-1 ROI. And 3 of our highest performing CACs have removed $3 million from the healthcare system every year. Where are we going next? We're going to what we call focused integration, which is a continued rapid growth in our CACs, newer technology to bring in interactive and near real-time data to share with the CACs, newer technology going to what Don was saying, integrating claims and clinical data and pushing it out in near real time as quickly as we can and technology will allow. Going deep with our successful CACs, targeting more high risk, which is the next thing we're doing is an integrated coordination team. The integrated coordination team is again centered around our embedded care coordinators. The CACs will provide the embedded care coordinators already like they're required to. Cigna will provide the rest of the resources. We'll have our case management. We'll have disease management where we'll have Cigna medical directors, both medical and psychiatric, available on the virtual calls at least once a month. They'll provide evidence-based guidelines. They'll guide the embedded care coordinators and if the primary care physician is there. We'll have behavioral people, including psychiatrists. We'll have a pharmacist on the call to help, if they have pharmacy benefits, to help coordinate that. And if they don't, we'll work with them on their medical reconciliation. The idea is to test 2 theories. One is a very focused integration to find the highest risk patients, the top 1%. And the second is to test two theories of how you identify high-risk patients. One is the typical way we do it with predictive modeling. The second is what our CACs told us is we can do it a lot better than your predictive modeling tool. And so we're going to test those 2 theories in a pilot to see which one actually works better at identifying the highest risk patients and which one has the greatest impact at quality and cost. So at Cigna, obviously, we believe in the coordinated care model, and we continue to invest, and our employer clients continue to invest significantly in this model.
Well, thank
Thanks.
you.